Very good question. So I think overall, a lot of things that apply to community oncology does not apply to hospital-based practices, right? As you know, that the practice setting is different, the way the methodology is different, the way the physicians operate is different, and some of these institutions are NCCN or NCI cancer centers. The way they manage care is a little bit different from how a community oncology practice manages care. So over the years, and initially our initial model was 2015, our model was primarily like an oncology medical home. We were a little ambitious. We had a lot of risk adjustment built into the model to understand cost differences that could be accounted for by advanced stage disease or early stage disease. We've also looked into doing a total medical cost model with episodes. So we've looked at the entire gamut. We get feedback. And it is not an easy thing to do on our side also. We also have a lot of administrative burden as we do try to operationalize these models. So it does take a lot of effort on our end to get the feedback in, to make the changes necessary. And then there's a lot of contracting language that goes into play, and several folks that work on the model to make things happen. So I would say that it's not an easy task, but we do try to get feedback from all the providers, including those, how Florida practices is not exactly how New Jersey practices. So we do take those comments into account as we do that. I think that, definitely, I think a lot of these large institutions, they have, let's say they have an entire division that works on breast cancer, for example. So they have breast cancer division, the lung cancer division, and each division operates a little bit differently. And ideally, when we implement models, we like to have like a single point of contact that is available to connect with our clinical resource or non-clinical resource, so that there's that collaboration between the two, between us and the provider as we move this forward. So, we have experienced some challenges because of the way they are set up and how their operations are set up. And so they don't necessarily have one nurse. They have, I don't know, probably 50 different nurses that do that function of navigator or coordinator, so to speak. So I think that's just one tiny sliver of things, but I think, a lot of the big hospitals, they also have consistent pathways or consistent methodology, the way they operate. They also have greater access to clinical trials. Community oncology functions a little bit differently. They, a lot of times, are able to provide that single point of contact. A lot of times their physician leadership is very closely engaged with our teams. They also have a team-based care where they're, the teams are smaller, the scales are much larger in a hospital-based system. I think that's probably like the best description I can give.
Okay.
When we started initially, we came out before OCM came out. And so we had, reasonable measures, and I can't remember every single one of them, but I think once OCM came out, we tried to align as much as possible with OCM to make it easier on providers. That being said, any minor change in the measure itself, measure definition, makes it a completely new measure. So OCM has a different methodology for collecting data from providers. And obviously we, as a Cigna Healthcare, I don't think has the resources that CMS has to be able to get that level of detail. So what we had to do was, at that point, make some, once we made the changes, and we had to relook at them, understanding the challenges providers had in submitting some of these codes, are they assessing pain management, for example, depression screening? Are they doing adequate depression screening and addressing those challenges with patients? So we tried to simplify at that point to say, okay, we will accept additional quality certification. So we've tried to simplify as much as possible. But, there's always administrative burden with any of these the value-based care models we're trying to do, because you're trying to change the way we practice and we operate as a oncology ecosystem. So I think we have made significant progress, I believe. But I think, like, as any change you make, like I told you, is going to make a change in our model and, you know, contracting language, things like that. So overall, we do take into account feedback. We can't, you know, we can't always respond to every single feedback, but we do make reasonable changes and try to simplify things, because it's important for us to keep it simple and standardized, because we are a national payer. So we want to make sure that it's a model that we can operate and implement and, you know, do it with as little burden as possible.